The following podcast is part of a certified educational activity titled Expert Perspectives on Novel Approaches to Therapy for ATTR Cardiac Amyloidosis. Access the entire activity and complete the post-test at peerview.com/YFD860. Downloadable slides and practice aids are also available.
Hello, my name is Ron Watellis from the Stanford Amyloid Center at the Stanford University School of Medicine in Stanford, California, and welcome to Expert Perspectives on Novel Approaches to Therapy for ATTR Cardiac Amyloidosis. Joining me today is my colleague Sarah Cuddy, the co-director of the Amyloidosis program at Harvard Medical School in Boston, Massachusetts. Welcome, Dr. Cuddy.
Yeah, thank you very much, Dr. Watellis. Delighted to be here and join you today on this interesting discussion.
Well, thank you. So, our goals for today are to help you keep the requisite high index of suspicion for ATTR cardiac amyloidosis, to equip you with strategies for diagnosing and treating ATTR cardiac amyloidosis, and to provide guidance on the benefits and limitations of current and emerging targeted therapies that are letting our patients live longer and better than previously possible. So, I'd like to start by talking a little bit about the pathogenesis of ATTR amyloidosis. So, the normal function of TTR transthyretin, also known as prealbumin, it's all the same thing, is to transport thyroxine and retinol. And it's produced almost exclusively in the liver. And as you can see, it circulates primarily as a tetramer. But over time, you will see some dissociation of the tetramer into monomers, which ultimately misfold and can deposit as amyloid deposits. Now, there are two broad categories of ATTR amyloidosis. One is the wild type or non hereditary form. This is by far the most common and really causes a predominantly cardiomyopathic phenotype, along with some orthopedic manifestations. The less common, but certainly very important, second kind of amyloidosis is the ATTR variant or hereditary form that's related to an individual having inherited a pathogenic variant, of which there are over 130 described. The survival with the disease used to be fairly dismal, particularly with the variant form, but really not great with often 3 to 4 year survival with the wild type form. Thankfully, as we will see, that is changing.
So, yes, as mentioned, we've both wild type transthyretin amyloidosis and hereditary or genetic or variant or mutant transthyretin amyloidosis. There's 130 different mutations in the TTR gene that have been identified, and here are some of the most common. Now, here we are using the older nomenclature. We've increased this by 20 amino acids. So V122I is now V142I. This is the commonest variant that we see in North America, and we see it predominantly in Black Americans, where the prevalence of this gene is 3 to 4%. However, what's kind of key about this is that the penetrance is incomplete. So we know in patients in their 60s, there may only be about a 10% penetrance. So only 10% of those who carry the gene will develop the disease. But this increases with age. Another common variant that we see in the US is T60A or T80A, and this can cause a mixed phenotype. So we can see both cardiomyopathy and polyneuropathy. And we can see this across different variants. The next commonest variant worldwide is V30M. This can be early onset, predominantly polyneuropathy, autonomic neuropathy, or late onset, which can be predominantly a mixed phenotype. So, we mentioned some of the clinical manifestations of transthyretin amyloidosis. Obviously, today we're talking about cardiac amyloidosis. So, the cardiac manifestations are heart failure, atrial fibrillation, often very challenging to control, may have required multiple ablations, or a patient may go into heart failure quite rapidly when they develop atrial fibrillation. We also commonly see electrical system disease, bradyarrhythmias, conduction abnormalities that can progress quite rapidly over months in some cases. These patients often require pacemakers, and it's in the evaluation for that presentation that we can kind of come up with suspicion for cardiac amyloidosis. As was mentioned, musculoskeletal involvement is common in both wild type and some of the forms of hereditary ATTR. We see carpal tunnel syndrome, commonly bilateral carpal tunnel syndrome, 5, 10, maybe even 15 years before cardiac manifestations are clear. spinal stenosis. So we can see that in cervical or lumbar spinal stenosis, biceps tendon rupture, which we refer to as the Popeye sign, and then lots of other kind of orthopedic manifestations. Polyneuropathy, we generally say, is due to the hereditary form of ATTR amyloidosis, but often some of these musculoskeletal issues can cause a compressive neuropathy as well. So it's just very important to ask about neuropathy when you've got a suspicion for cardiac amyloidosis. Or if you've a patient with neuropathy, it's definitely something to think of. Autonomic dysfunction driven by autonomic involvement in hereditary ATTR is also something to kind of be aware of. Orthostatic hypotension, this intolerance to blood pressure medications, which we actually see in both wild type and hereditary ATTR amyloidosis. More GI symptoms are seen in the hereditary form. Chronic diarrhea, constipation, weight loss, erectile dysfunction is a very common manifestation. So, as Dr. Watalas went over, we know the pathogenic process. So, what's really exciting now is that we've ways of targeting this. Liver transplant is really now, I think, relegated to the history books because we have replaced this with really effective therapies. So, first, kind of targeting production of the TTR at the level of the liver, we have gene silencers. Eplontersen, patisiran, and vutrisiran. Vutrisiran has the heart beside it because it's the one approved for ATTR cardiomyopathy. The others are approved for hereditary polyneuropathy. We also have exciting preliminary data on using gene therapy, CRISPR, which we'll go into later on. Then we can also target the tetramer itself and aim to stabilize it with different molecules. Tafamidis and acoramidis are both approved for this indication, and we'll go into the trials that kind of supported that approval. So, all of these therapies are targeting the precursor protein to stop it from misfolding and forming more amyloid. So, really, what we're doing is just really slowing down the disease, maybe even halting it, but we're not causing kind of improvement. And that's where there's a lot of interest and excitement about amyloid directed antibodies or fibril degraders. Again, we've got exciting preliminary data on this. So, what raises the suspicion? As I mentioned before, we have those clinical manifestations. And obviously, often when you've got a cardiac presentation, the next thing you're going to do is an ECG and probably an echocardiogram. ECG, I think historically we would say low QRS voltage, but this is present in maybe less than 40% of patients with ATTR cardiomyopathy. Generally, when I'm in clinic, I think of it more as something I associate with AL amyloidosis than ATTR amyloidosis. And definitely, we can see patients in our clinic who even meet voltage criteria for left ventricular hypertrophy on their ECG. Um, Pseudo infarct pattern is very common in these patients. And then when it comes to the echo, there's several features. The increased wall thickness is really key feature to help make the diagnosis. And I always find looking at the posterior wall thickness on echo as a very helpful indicator if there's some pathological process going on, if that's 12 millimeters or more. But then kind of really one of the clear signs and things we encourage to see, if you see any kind of suspicion for cardiac amyloidosis, that increased wall thickness, atrial dilation, abnormal diastolic function, if you can do strain, that can really increase the kind of sensitivity for picking up cardiac amyloidosis using echo. And here we see examples of an abnormal strain pattern, what we describe as the apical sparing pattern or cherry on top. And this can often become more prominent as the disease becomes more advanced. So we can think of some kind of common scenarios where the suspicion for ATTR cardiac amyloidosis may be higher, where it might be an alternative diagnosis to consider. A lot of studies have shown a high prevalence in older patients with aortic stenosis, particularly those referred for TAVR. And we've seen this in multiple studies from multiple centers. We think the prevalence probably in the TAVR referral population is around 8%. We've also looked at several populations with heart failure. So, particularly looking at those with heart failure with preserved ejection fraction, increased wall thickness on their echo over the age of 65, and heart failure. The prevalence with those admitted with heart failure in an inpatient setting can be up to 13%. In the community, this is probably closer to 7%. So, these are kind of key populations to consider cardiac amyloidosis and specifically ATTR cardiomyopathy.
Great. Thank you, Dr. Cuddy. So I'm now going to go through the diagnostic algorithm for cardiac amyloidosis. And the main thing I want to get across is it's not that hard to do. There's really just a couple of steps once you have clinically suspected cardiac amyloidosis, looking at some of the scenarios that Dr. Cuddy just went through. So the first thing to do is to make sure there is no monoclonal protein present, because if there is, that raises the possibility that the patient could have AL amyloidosis. And we want to do that with three tests: the serum free light chain assay, which I'm going to say a little bit more about on the next slide, and then a serum and urine electrophoresis with immunofixation. And what we're looking for here is, again, is there any monoclonal protein that we can detect in the blood or in the urine, which tells us if it's present, there is the potential for AL amyloidosis. If that is the case, you must move on then to biopsy. And the place to biopsy is debatable. I would generally go straight for the heart because it has nearly 100% sensitivity and specificity in this disease. If you want to start with a fat pad biopsy, you can, but keep in mind that you can absolutely miss cases by fat pad biopsy. And in fact, for ATTR, you will miss it most of the time. So if that fat pad biopsy is negative, you still need to move on to the endomyocardial biopsy. Most patients, however, will not have a positive monoclonal protein. And then you can move on to bone scintigraphy, which most commonly in this country is done with technetium pyrophosphate, or PYP. We're going to see some examples of that in a moment, but it takes advantage of the fact that amyloid deposits like to take up bone tracers, and normally you should not see a bone tracer taken up in the heart. So if you see significant uptake, where the uptake is equal to or more than what you see in the ribs, then that's a positive scan, and you have now diagnosed the patient with ATTR cardiac amyloidosis. All that's left to do is genetic testing to see if they have the wild type or hereditary form. Now, a couple of words about the light chain levels. Light chains are produced exclusively in the bone marrow, but it's produced at about a 2-to-1 clip, kappa to lambda. They are cleared in two different ways: the reticuloendothelial system and the kidneys. And normal kidneys clear kappa really, really well. And so, for that reason, even though kappa is produced a little bit more in the bone marrow, in a young, healthy person, you'll tend to have a mild lambda predominance. But as people age and develop kidney dysfunction, you will see the kidney portion of the clearance getting less and less. And now you start seeing a relative rise in the kappa light chains as compared to the lambda. What does that mean? It means that the normal level that comes back on the free light chain ratio has to be adjusted for kidney function. You've seen here some proposed normal ratios. The key to recognize here is if you have a normal serum and urine electrophoresis, a mild kappa elevation in that 2-to-1, 2.5-to-1 can be considered normal. But you start getting much above that, or if you have a lambda predominance, that should be considered abnormal.
Yeah, so I'm going to give you an example of a patient who was referred to me just to go a little bit more into that cardiac scintigraphy with the bone avid radio tracers. And as Dr. Watala has mentioned, predominantly PYP in America, but there's been recent shortages of that radio tracer, so we've been using HMDP a bit more. This was an 89-year-old woman who was referred to me with a positive scan. So, and in our practice in our center, we review all imaging before we see the patients. So these were the images that were sent to me, and it wasn't kind of the primary image that I could open and close. It was JPEGs of the image. So here, first we see a planar image with two regions of interest drawn. And kind of initially, when this technology was being adopted, a lot of the publications were on the benefit of using planar imaging and calculating this heart to contralateral ratio, where you draw a region of interest over the heart and one over the contralateral lung. And we can see here in small writing that this ratio was 1.3. So technically, the ratio that we would have used would have been 1.5, but that was at 1 hour. There was some publications saying if you did 3 hour imaging, you could use a ratio of 1.3, but we'd probably call it equivocal. Now, actually, the American Society of Nuclear Cardiology strongly recommends against using planar imaging at all to make the diagnosis and really to concentrate on the SPECT imaging. So here we see the SPECT imaging, and yeah, there's uptake. It looks like the uptake is equal to the rib uptake that I can see, but I'm not exactly certain if the uptake is within the myocardium or if it's within the blood pool, because often we can see radiotracer activity within the blood pool. So we weren't sure of this, so we decided to call the patient in and repeat their scan. So when we again look at the SPECT from the outside center, we repeated the SPECT here at the Brigham, and we do SPECT CT on all patients. And we find the CT really valuable because we can register with the myocardium and where we expect uptake. And you can see here, we see no myocardial uptake. There's kind of a faint hint of activity, but it's kind of generally all over the heart. So kind of blood pool myocardium equals. So we call this a negative scan. And we are actually able to take this patient off medication and reassure her that she'd no amyloid. One of the key things I want to say here was we reviewed her echocardiogram, and her echocardiogram did not have all the features of amyloidosis. And the original paper by Gilmore et al. In 2016 that was used to validate using the bone avid radio tracers for cardiac scintigraphy was in the setting of typical imaging on echo or MRI. So if your echo has normal wall thickness, the atria are not that big, we can't really be certain that you have a diagnosis. And maybe if you want to look for another etiology or be certain it's amyloid, MRI can be helpful there as another kind of imaging tool to use.
All right. Well, now I'd like to ask the question: does every ATTR cardiac amyloidosis patient need a multi-specialty center? And I think it's in vogue to say yes. And the two of us both co-direct large amyloid centers, so I suppose we should say yes. But I actually would argue probably the answer is no for ATTR amyloidosis. That for AL it really is critical, but for amyloidosis, it's really not that rare. And most patients are wild type disease with really cardiac manifestations as their only vital organ involvement. And I think if we say that every patient needs to be referred to an amyloid center of excellence, the only way that can happen is if we're not diagnosing enough patients. So I would like to see this democratized and not say every single patient needs a multi specialty center. But Dr. Cuddy, what do you think?
I'm somewhat in agreement. I'm a little bit hesitant just around the diagnosis because of the last case I showed. So I think if you can be certain you're working with like experienced cardiac imagers or a good nuclear medicine, nuclear cardiology program, that you're making the correct diagnosis. And maybe even if there's like an expert that you can say, I think I have the right diagnosis, but I think longitudinal care of an uncomplicated patient can definitely be managed outside a specialist center. And I agree with you. We really need to democratize this.
Thank you. Now let's move on to the really exciting world of treatment. And for ATTR cardiac amyloidosis, at the present time, there are three FDA approved medications: two of the stabilizers, tafamidis and acoramidis, and one silencer, vutrisiran. And we saw the mechanisms of action of those earlier. We're going to go into the data here for just a moment. What I would emphasize is that all three of these are really very, very safe and well tolerated. And so, from the standpoint of deciding therapies, thankfully, that part is not a big portion of it. Now, the one thing that is different is that the first two, the stabilizers, are both oral versus vutrisiran, which is subcutaneous, although it's only every 3 months. So, for some patients, that makes a difference. Vutrisiran has the indication for both cardiomyopathy and neuropathy. The other two have it only for cardiomyopathy. So, for a patient, for example, with mixed phenotype disease, vutrisiran can be an excellent choice. But for the patient who has just cardiomyopathy, any one of these three is a good choice, as we'll see in just a moment. And so I'd like to start here with the original agent that was proven in ATTR cardiac amyloidosis, and that is tafamidis. And it really did change the paradigm. What you can see is that in the ATTRACT study, which was the double-blind, randomized, placebo-controlled phase 3 trial of tafamidis, that there were really dramatic differences. So you see all-cause mortality on the left. Here we can see also combining with the long-term extension study. But you see that while it took about 18 months or so for the curves to separate, once they separated, they really separated. And you saw that earlier for cardiovascular hospitalizations, and even earlier, as we can see, with 6 minute walk and KCCQ. It's important to note with all of these markers that tafamidis is not a cure for the disease, and it doesn't halt progression of the disease. If you look, for example, at 6 minute walk or KCCQ, there is still drop with time, but it dramatically alters outcomes and was really a game changer for the disease.
Yeah, and this was followed by the ATTRibute-CM study, which looked at the efficacy of acoramidis, another TTR stabilizer. So, one of the key things about this trial is that it started after tafamidis had closed and read out. So, that was a different kind of patient population, we might say. So, a more contemporary patient population enrolled into ATTRibute, which started enrolling in 2019. Slightly more patients, over 600, randomized 2 to 1. And we looked at the same kind of endpoints in a similar fashion, this hierarchical assessment of death of any cause and cardiovascular related hospitalization, with the addition of 6 minute walk test and NT-proBNP as key endpoints. And this again was a positive study, which led to the approval of acoramidis last year in November 2024. And we can see here again, similar in the secondary endpoints, it really attenuates the increase in NT-proBNP. We see also that the 6 minute walk distance does not decline at the same rate. The curves are later to separate than the ATTRACT study. Again, probably for the reason I mentioned, that it's a healthier population that were enrolled in this study at baseline. And that's what we also think we see in the Kansas City cardiomyopathy questionnaire. One of the other endpoints looked in this was change in serum transthyretin level or prealbumin level, as this stabilizes the tetramer. So we see an increase in this in the serum.
Great. And then the third agent is vutrisiran. And again, that is a silencer. So this is acting to knock down the liver's production of TTR. And so the phase 3 clinical trial for this was called HELIOS-B. And it was a 655 patient trial with a primary endpoint of composite of death from any cause, as well as recurrent CV events, mainly those being hospitalizations, as well as some urgent heart failure visits. Now, importantly, 40% of patients were on tafamidis at baseline. Another 20% or so who weren't on it dropped in during the study. So it's though the trial was not designed to look at patients on combination therapy per se, there were a substantial number of patients who were on the baseline stabilizer and then were also randomized to the silencer or placebo. What we can see on the curves on the right is really, again, a dramatic difference in both all cause mortality in the curve on top, as well as the CV mortality and CV events, mainly hospitalizations at the bottom. Once again, you can see the curves don't separate right away. It takes a little bit, a little quicker than with ATTRACT, but it still takes, in this case, about 15 months or so for mortality and about 9 months or so for the others. But as they separate, they really keep separating. And again, important to note, much more contemporary population, and many of them were treated on tafamidis as well. Once again, we can now look at some of the secondary endpoints, the 6 minute walk and KCCQ scores. And I want to point two things out. One is the curves on the top. These are mean changes in 6 minute walk and KCCQ, but this is also using imputation to basically say if a patient died or couldn't complete the test, we're going to assume they would have done pretty poorly. And whereas on the bottom, you see the median change in 6 minute walk and KCCQ, where now it's just what does the true middle patient do? And so what you can see is that by the mean changes, you still do see a drop that is not too dissimilar, I would say, to what we saw with acoramidis. When you look at median change, this is when you're counseling the patient, what is that person right in the middle? What happens to them? And you can see that the patients in blue on vutrisiran really had stability on 6 minute walk and KCCQ over the 30 months of the trial. Now, in addition, there's this question about combination therapy. So the trial was designed to look at both the overall population and then the 60% or so who were not on tafamidis at baseline, the so-called vutrisiran monotherapy arm. And as you can see here, looking at all-cause mortality in the monotherapy arm, clear difference favoring vutrisiran. Now, there's a lot of interest to say, hey, it makes a lot of physiologic sense to combine a stabilizer and a silencer. Maybe that would be even better. Now, I want to emphasize again, the trial was not powered or designed to answer that question. Nevertheless, of course, there's interest in the data. So you can see the data on the right. So this is everybody here is on tafamidis. This is randomized now. Do they get placebo or vutrisiran? And you see a trend in favor of vutrisiran. That is to say, the combination therapy trended better than patients on tafamidis alone. But you will note the p-value is not statistically significant, nor would we expect it to be because it was not designed to answer this question. So I would say this still falls under the great unknown.
Okay, so I think overall this is a happy story, as demonstrated by this study, where we see increased survival over different time eras in the care of patients with cardiac amyloidosis. So we see how the curves in both overall ATTR cardiomyopathy and ATTR cardiomyopathy due to the V142I or 122I mutation have really improved to now where they're at 2017 to 2021, and maybe arguably have gotten even better. We don't know. Um, so I think, we've done a lot. We have more to do. And some of that probably poor survival in the V122 patients could be other determinants of health in that kind of population group that we really need to start looking at closely. So, what we use for our prognostic factors or staging at the moment, and there's a few different staging systems out there, but the most common is probably from the National Amyloidosis Center in the UK, which was led again by Julian Gilmore and published in 2018. And I think why a lot of us use this is its simplicity. It just harnesses NT-proBNP and EGFR, two very easily acquired laboratory tests that we can get at each clinic visit or at baseline clinic visit for sure to help prognosticate. There is other staging systems, one from the Mayo Clinic that uses troponin, and then a more recent one from Columbia that integrates diuretic dose and MYHA class. So that's kind of the question now, as I mentioned. We can collect some of these labs pretty easily at each clinic. So how should we monitor these patients is a major question. I've been doing labs, 6-minute walk test, and I want to know, Ron, how do you monitor patients over time? And should we be monitoring? Is it important?
Well, I've always been, I'm sometimes accused of being a bit of a nihilist with this. And I would say that until recently, I didn't actually follow many of these things because it didn't matter. We had one therapy available, or prior to that, no therapies. But let's say in the tafamidis era, we had one therapy. The patient was going to pretty much get it no matter what, whether these were looking stable, increasing, or decreasing. And so I don't like doing tests when they're not actionable. There's obviously a lot more interest in this now to say, well, there's now three FDA approved therapies and maybe more on the way. But what we don't know is if a patient is showing worsening in one or more of these, let's say their NT-proBNP is going up despite being treated with one therapy, does that mean the therapy isn't working, or would it be even worse if they weren't on that therapy? So we don't actually know that switching in that case from one therapy to another will benefit the patient. But there's at least a little bit more rationale. So I confess that I do look at these more, particularly things like biomarkers and prealbumin levels. Do you do the same?
Yes, I have been doing most of these. I can't say I subject the patients to a KCCQ every time they come to clinic, but I do get them to walk up and down the hall for me. And I think there's a lot of interest in using the TTR levels or prealbumin levels. Some of this comes from the data from the Attribute trial, which I showed earlier, that increase in serum TTR levels with therapy. And that's been shown that the degree of increase is related to outcomes. Now, can you use this on an individual patient level? Well, this is a negative acute phase reactant. So I have found it challenging in clinic. And, I don't want a patient to get discouraged if I'm tracking it over time and they see a drop and they say, oh, is the medication no longer working for me? Or I'm like, did you recently have a flu or a pneumonia that could have affected this? So we kind of have to remember that prealbumin, it's not just measuring this. There's lots of other impacts that can be on those levels.
Great. So sometimes, speaking of nihilists, sometimes I will hear people say, "Oh, this patient's too old. Am I really going to prescribe this medication, particularly a expensive medication? Is it going to make a difference?" And generally, the answer is yes, you should. So this was data from the ATTRACT trial and the long-term extension. Again, this was with tafamidis, and it was looking at the octogenarian patients. And again, of course, this study was not powered for the octogenarian patients who were a subset of the whole trial. But you can see here that looking at survival, that there's a clearly big difference as you look at the patients who are randomized to tafamidis or to placebo. There have been other data that have come out, observational data as well, from centers looking at their octogenarian or even nonagenarian patients who have the disease, who are or are not treated with tafamidis. And you can see that the patients who get treatment do better. So, of course, use your clinical judgment. If you have a patient who has advanced cancer, advanced dementia, of course, it may not make sense. But in general, yes, patients do better. And remember, it's not just about living longer, it's about feeling better as well. So we should close with looking at the future. And so we talked about the three approved therapies for ATTR cardiomyopathy, but there are potentially more on the way. So there's another silencer, eplontirsen, that is being studied in the CARDIO-TTRansform trial, which is 1,400 some odd patients, so a very large trial that we expect the results in 2026. And then there's the gene editing approach that we'll say a couple more words about, as well as the depleters. Here is the gene editing approach. This is with an agent called NextZ. It's extremely exciting. What is so attractive about this is two things. Number one, you can give a single intravenous dose and you should have permanent reduction in TTR levels. So you don't need repeat dosing. And you can see that here on the left. This is following patients out to 24 months. And you see they get the dose, it immediately drops the TTR level, and then it stays there. That's one dose. And we wouldn't expect any rebound if you follow them for another 24 years, much less 24 months. The other thing that's exciting is the level that it goes down to. So in this study, it's about 90% drop, which is really terrific. What you can see now, this is from phase one data with KCCQ and a 6-minute walk, but you really see stability in those two markers. Take that for what it's worth. It's phase one data. I wouldn't take that for too much, but what we're all very interested in seeing is the results of the phase three study with this agent, a randomized double-blind placebo-controlled trial called Magnitude.
Yeah, and as I mentioned earlier, a lot of our excitement is about trying to remove the amyloid. Can we actually not only treat the disease to slow it down, but cure it, remove the amyloid? And very exciting phase one data, specifically looking at the MRI measure of amyloid burden, which is extracellular volume, is a proxy for amyloid burden. And we see kind of pretty marked reductions, up to 20% reduction in ECV in the phase one study. So again, the phase two study the phase three study is fully enrolled. So we'll anticipate results of that in the coming years.
Well, wonderful. Well, I just want to highlight the key takeaways from today's session. So, first is that ATTR cardiac amyloidosis requires a combination of laboratory testing, imaging, and genetic testing to accurately diagnose it. There are now 3 FDA-approved targeted therapies for cardiac amyloidosis from ATTR. It's tafamidis, acoramidis, and vutrisiran, all of which are effective. They reduce morbidity and mortality, and they're all very well tolerated. There are more important questions that remain to be addressed. Some of the ones that are hot topics is, can we prevent ATTR cardiac amyloidosis in people at high risk who are carriers of variants? What about this question of combination therapy? We don't know the answer. Lots of interest there. And as we discussed, how should patients be monitored, or even should patients be monitored for quote unquote disease progression? And finally, I would say that this is an area of intense research interest. You saw some of the trials that that are ongoing. That's not even a complete list, with additional TTR silencers, the gene therapy, and the monoclonal antibodies that are in development. So, with that, that concludes our discussion for today. I'd really like to thank Dr. Cuddy for her wonderful insights and this terrific conversation.
Yeah, thank you very much. It's been an absolute pleasure.
Well, I hope that you've all found this activity informative and updating your understanding of recent advances in the standards of care for the management of ATTR cardiac amyloidosis. Please don't forget to download the slides and use the accompanying practice aids. And I hope that you feel more confident about using targeted therapies for ATTR cardiac amyloidosis after watching this session. Thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Alnylam Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/YFD860.